So good afternoon and welcome. My name is Wright Pinson. I serve as the Deputy CEO here at Vanderbilt University Medical Center. And on behalf of the Medical Center, I'm delighted to kick this discussion featuring Mark Cuban and two of our colleagues on prescription drug pricing and the innovations that are changing the outlook for millions of Americans. I want to welcome Mark. I want to welcome his daughter. We're glad that you are with us here at Vanderbilt University. I also want to welcome our Vanderbilt University colleague, John Lutz, who's here representing Chancellor Diermeier today. Joining the discussion today is Rushi Talwar, who is a urologic oncology fellow here at VUMC and an American Urologic Association H. Logan Holtgrew Legislative Fellow. She's an accomplished health policy researcher and a national leader in advocacy with organized medicine. She makes several trips to DC each year for congressional visits related to healthcare legislation. The last time I was in to see my urologist, Sam Chang, I could not get him to talk to me about my problems. All he wanted to talk about was Rushi. It's the truth. So recently, Dr. Talwar published a study demonstrating that Medicare could save about $1.3 billion by purchasing urologic drugs through Mark Cuban's Cost Plus Drug Company. And she is working on an additional analysis exploring the economic impact of the company on both Medicare beneficiaries and taxpayers for anti-cancer drugs. So Mr. Cuban, as you may or may not know, is an entrepreneur. In fact, you might describe him as a captain of industry who, among other things, is interested in professional sports. I was pleased to note his enthusiasm last night for certain aspects of professional sports. He's also an investor in the ABC television show Shark Tank, and as I just said, he's a founder of the new prescription drug company Cost Plus Drugs, and they are interested in figuring out how to discount prices on certain cancer drugs related to urology. So Stacy Dusetzina is a professor in the Department of Health Policy. She's an Ingram Professor of Cancer Research and a national leader in drug pricing research. Her work on access to high-priced medications for Medicare beneficiaries has informed the provisions in the Inflation Reduction Act, saving an estimated 50 million older Americans significant out-of-pocket costs each year. So I want to thank Mark Cuban. I want to thank Dr. Talwar and Dr. Dusetzina for joining us today in this timely and forward-thinking discussion. We are proud that the Vanderbilt University Medical Center community is leading the way on improving access to prescription drugs in these ways. Again, welcome.
Good afternoon, everyone. We're so thrilled to have you here with us today, both those of you joining us in person, as well as those joining on the live stream. Dr. Pinson gave such a wonderful introduction for our panelists here today, but I'll just give you a brief background on their interests and what we'll be chatting about. First, I'd like to introduce Dr. Stacy Dusetzina. Dr. Dusetzina is a professor in the Department of Health Policy here at Vanderbilt. As you heard, her work has informed some major provisions in recent legislation that's improving prescription access for millions of Americans. Next up, really needs no introduction, but I'll give it a shot anyways, Mr. Mark Cuban. He's an entrepreneur, a businessman, a television personality, and most recently, a big disruptor in the pharmaceutical space. So thank you both for joining us today. We're going to dive right in. Stacy, why don't you start by giving us an overview of the current state of prescription drug access in America?
Sure, thanks. And it's great to be here with both of you. So I think to level set at the beginning, when we think about access to prescription drugs and even things like generic drugs, there are a couple of key problems with our system today. The first is that there are many people who remain uninsured in the US. So 8% of the population, according to recent estimates, don't have access to affordable health insurance. So for them, paying cash is the only option. Then we have a problem of underinsurance. So even those of us who are fortunate enough to have health insurance, we often don't have coverage that actually meets our needs. So we may have to pay high deductibles, pay co-insurance, a percentage of our drugs cost, and we may find that it's not affordable to us to be able to take the medications that are prescribed to us as we are intended to take them.
Yeah, it's a major issue. But Mark, you've been doing some work to try to shake things up. So why don't you tell us about your journey with Cost Plus?
Oh, goodness. It started probably about 6 years ago. I got into healthcare for a variety of reasons, but to shorten the story, about 4 years ago, I got a cold email from a radiologist, Dr. Alex Oshmayansky, and he was talking about doing a compounding pharmacy in Denver where we would make generic drugs that were in short supply or overpriced pretty much on a per order basis. And this was right around the time where the pharmacy bro was doing his thing. And I just replied to him, well, if this idiot can raise prices by 7,500%, the market must be so messed up. Somebody should be able to cut prices in an equivalent manner. And that effectively was the genesis of Cost Plus Drugs. And so fast forward to January 19th of 2022, we launched with costplusdrugs.com. And where we really tried to be different was through being radically transparent, because we all, can look at invoices and look to see at the pharmacy what's on our bill for what we pay, or what, if you're involved in the insurance side, what the payer pays, but nobody ever knew what things cost.
Yep.
And so we felt that by showing our cost and being completely transparent, we could change the industry. So when you go to costplusdrugs.com and put in whatever medication, and if we carry it, up is going to come information about the drug, but you also see what we pay. And then you'll see that we mark it up 15%. You'll see that there is a pharmacy fill fee of $3, and that may go up now because our costs going up. We're looking at raising that to $5 here in the next couple months, and then a $5 shipping charge. But that's it.
Yeah.
So you know exactly what we pay. And compared to an industry, particularly for pricing for medications, that is completely opaque, and where the less information available, the more patients can be charged, it was just a game changer. And so we launched and started shipping our first drug January 19th of 2022. Here we are, March 23rd of 2023, and we have more than 2.1 million accounts.
That's incredible. Yeah. That's incredible. So I understand the transparency and your model with the 15%, but tell me a little bit more. Compared to other pharmacies or other companies out there, how is Cost Plus able to keep their drugs pricing so low?
By staying simple. If you're going to be the low-cost provider, you have to have low costs. And so you're not going to see a blog from the most famous urologist on the planet. You're not going to see.
Not me.
Yeah, you're about to be, right? Yeah, you're about to be. And you're not going to see any of the bells and whistles you're going to see from some other sites that really try to be fancy. We don't have an app. We just have a website, and we keep our costs low. Yeah. And that allows us to keep our markup to 15%. And what it really comes down to, it was a conscious decision on our part. We could have, reduced some of the friction in certain areas, but then that would have resulted in increased costs. And in an era where it's still crazy that people in this country have to choose between rent, food, and whether or not they'll have to ration their medication, we felt like if the delta in price or cost saved one more person, that was the direction we wanted to go.
Yeah, yeah. Now, when we talk about this space, a lot of times people reference things called PBMs, or pharmacy benefit managers. I know that that definitely plays a role in things that you've spoken about in the past. Before we jump into that question, Stacy, can you first provide us an overview of what PBMs are and the role they play in our healthcare industry?
Yeah, absolutely. So PBMs get defined very clearly as the middleman in the transaction, and that's probably how Mark would be thinking about them as well. In some ways, they add some cost to the system, and one of the big things that we don't know is how much cost. There's a total lack of transparency in the current system when it comes to PBMs and how they're paid and how much they're paid. But they started out functioning in an important role. So a lot of times employers and large groups would need to purchase health insurance services and pharmacy services in particular through one large negotiator. So PBMs serve as a negotiator for health plans and employers, and they set formularies and then they manage benefits in a way that can be much more helpful than if every single employer tried to do this on their own. One of the challenges over time is those markets have become incredibly concentrated. So very small number of PBMs control most of the market, and they also have become part of health plans. And so the financial model that they're using, we know is increasing some of the costs or is contributing to the costs of drugs, but also we don't have the transparency to know exactly how to fix that.
Mm-hmm. What are your thoughts, Mark?
I would tell you that PBMs have created issues. Obviously, they've added a lot of opaqueness and confusion, but PBMs are just one component of a much bigger organization. And what's ended up happening is they've done a great job of saying, look over here at the PBM. Right? Ignore the fact that we also own the retail pharmacy chain. Ignore the fact that we own the insurer. Ignore the fact that we own these copay consolidators and all these other, 200 subsidiaries. And so what's ended up happening is, to Stacy's point, the entire pricing and costing in this industry is completely opaque.
Yeah.
Nobody knows anything. And so while we're dealing with the cost of drugs, I think the PBMs have been a lot smarter than a lot of the politicians. Not that that's a shock, but because they keep on saying, look, it's not really the PBMs, it's not really the PBMs, but ignore everything else. Mm-hmm. And so what we fail to realize is that you have to look at their organizations holistically. Mm-hmm. That because on one hand they'll say, okay, we're going to reduce the cost of insulin, or we'll accept a reduction in cost of insulin, but the insurance company is going to raise their premiums, and we're going to collect some more money at the pharmacy. Mm-hmm. And we've got this other system of technology that is going to evaluate all this and charge you more for each transaction. Mm-hmm. So we'll make it up all over there. Mm-hmm. Where I think from a policy perspective, when you look at these companies holistically, you just have to ask the question, who takes less? Mm-hmm. Yeah. When you look at insulin, it's great, for the IRA for Medicare patients to get insulin at $35 a month. Great, right? But who gets less? Mm-hmm. When you look at what Lilly announced, it's great. And I think, them stepping up and changing this was phenomenal. But again, they've already come out and said many times that their net effective revenue is $22. Mm-hmm. Right now, maybe per month, I don't know what the average insulin usage per month, number of vials, et cetera. So maybe they are taking less. But from a policy perspective, we have to ask the question, whenever we try to set pricing, who gets less? Mm-hmm. Because while it looks great from a political perspective, we are going to cut prescription drug prices. That's not the only cost in the supply chain for patients. Mm-hmm. Yeah. You have to look at the whole thing and see, okay, on an aggregate, who gets less? And we're not doing that. And that's why, even though there's a lot of talk from the top, and President Biden, rightfully so, says, let's change pricing, we're going to get prescription drugs lower. Well, pick a drug. And if I was paying 10, or if I was paying 100, and now I'm paying 20, but I'm paying $84, 5 other places, they're making more money, but the soundbite is great.
Yeah, I hear you. So, with that, let's talk a little bit about the role of insurance companies now. I think it's interesting that your company right now, as it stands, does not accept insurance.
Well, we do accept insurance, but only from companies that agree to no rebates.
Correct. So tell me more about that.
Yeah, if you're an insurance company that plays it straight up and doesn't play games with rebates, we want to work with you. Because look, like the Blues, right? They don't like all the rebate games. And, we've had great success working with Capital out of Harrisburg, Pennsylvania. And the people in their plans love working with us and saving the money. And it, makes the insurance company in that particular case more money. And hopefully they pass all that through. But when you have an insurer that's captive to a PBM, all bets are off.
Which most of the large
The biggest three are.
ones are.
Yeah.
Correct. And that's why I find it really interesting that even if you're not using insurance, your pricing's a lot lower than even just a copay in most cases.
And the bigger question is, is the concept of insurance, health insurance, outdated? Because we've gotten to the point now where prereqs, every type of authorization you can imagine, every delay, the fact that, and you guys know this better than me, cash pay can be 60, 70, 80% less than what you negotiate with the biggest insurance companies.
Yeah.
Which is on its face insane until you start to understand it's because every year there's a new contract for every insurer or every 2 years. And that adds, they say it's 20% of overall healthcare costs. It's probably 30%, and it keeps on going up. And so the question becomes, we saw it with banks. If the Federal Reserve is the backstop for depositors, maybe, we should look at a government that comes in and acts not to pay all of it, but to be the backstop for people, because insurers are not insuring any longer.
Yeah.
And if you go back to the original history of insurance, right, it was in a community to try to keep the cost of healthcare, affordable to everybody in the community. Everybody kicked into the hospital $10 a month or $20 a month. And if you go back to that, and if Vanderbilt, not trying to put words in everybody's mouth, but if Vanderbilt just went to the Nashville community and said every business kicks in this, every person kicks in this, and we're not dealing with traditional insurers anymore, so there are no pre-auths. Everybody just says, here's what we want from our community hospitals. It'd be a much more manageable beast, because that insurer just adds so much complexity that there's no way it's ever going to work.
Yeah.
It is, healthcare in this country is doomed to fail because of the way the payer models work.
You are preaching to the choir here. You said the word prior auth a couple times, and I'm trying not to be triggered as a physician. But let's talk about another payer. Let's switch gears to Medicare. So 49 million Americans, receive health insurance through Medicare. And our study, actually, that put us in correspondence way back when, demonstrated a $1.29 billion cost savings if only urology drugs were purchased.
And how many drugs were there?
Yeah, it was only about 9 drugs. So if you calculate the cost of those 9 drugs multiplied by the number of times those prescriptions were administered, it's staggering. But Stacy, tell me a little bit more about the state of Medicare prescription drug pricing now, and what are your thoughts on the way Cost Plus can disrupt in this space?
Yeah, I think it's a great question. And going back to one of Mark's points about the health insurance coverage for drugs, or more broadly in that system, I think it is important to remember, like, Medicare beneficiaries' access to prescription drug benefits only started in 2006, which is not that long ago. Before that, drugs were relatively inexpensive and you could pay cash for them, and most people did so. And I think probably because most people were paying cash, the prices needed to be low enough for people to do that. So we have built a system to incentivize prices to go up and up and up and up, and we have to dismantle that system if we want prices to come back down. I think for Medicare beneficiaries today, obviously there have been several studies, including your own, about the cost of generic drugs, especially in Part D, and how much savings could be achieved through Mark Cuban's company. One of the challenges is always, like, who pays. So if you thought about, for example, everybody in Medicare going outside of their benefit plan, because we know that benefit is dominated by several large payers who have their own PBMs and pharmacies. So patients would need to go completely outside of their benefit and pay cash in order to really get the most benefit. That would save Medicare a lot of money because they wouldn't have to pay anything. So it's great for Medicare, but maybe is a little bit suboptimal for some of those beneficiaries. I do think it's important to recognize that Medicare kind of is aware, like CMS is aware that people have some challenges with generic drug access, and seeing how much more they're paying than what you could pay through Mark Cuban's company. I think has triggered some recent policy development. So CMMI, the Innovation Center, has just announced a demonstration project with $2 generic drugs for 150 products that I think they're hoping to launch in the next year or
But that
two.
brings up an interesting question,
Yeah.
right, on the $2 drugs. Who pays less? Who gets
Yeah.
less revenue, right? Because just to make and to ship,
Yeah.
And to fill is going to be more than $2.
Well, so they do say high value, right? So their intent, and they have not said which drugs these will be. Their intent, I think, is that these are products that in the long run, if you think about the benefits to the Medicare program, it will offset the cost to Medicare by lowering medical spending for people who have both parts of the benefit. But again, that's a complicating factor of Medicare, is that private plans are running part of it and don't have that financial incentive to lower medical spending the same way that the
Talking about
government
Medicare
would.
Advantage.
Fee-for-service Medicare is separate. Medicare Advantage does have they do tend to cover generics a little bit better because they actually are responsible for that medical spending.
So that brings up the next question. Why don't they just buy from us or somebody like us?
Can you handle the volume?
Yeah. Because think about it.
Well,
I mean,
we'll talk after.
yeah. I mean, because think about it. The people that we buy from, they're going to be the same people they buy from.
Yeah.
Right? Or supposed to, right? But they ended up going through a middle,
Well, like you said, but who's getting more right now? That's why private plans run the Part D benefit. Private plans, their PBMs, their pharmacies, they're making money right now as the system as it is. So I think that the government should have an incentive to buy from you, to go to the lowest cost.
I mean, the smart thing to do would be like, if I'm running CMS, right? I'm saying, okay, here's how many patients we have. You manufacture this drug, we need X number of doses, give me one price.
Yeah.
One price fits all, right? Like Netflix, right?
Yeah.
And this is how much I'm going to pay you for the year, as much as I can consume. So there's no price, right? And I know I have a fixed cost at Medicare. I know what their medications is. It's like there was a company in the industry that was in the insulin business that got sold. And the price that company was purchased for, if CMS would have just bought it, they could have just distributed insulin to everybody for, costing a little bit. Somebody's got to start thinking more like a business person to
Yeah.
understand that there are better models and better approaches to solving this problem than just saying, okay, we're the government, we're stupid. Let me go hire, a third party that's supposed to be smarter. And that third party just sees us coming and just takes as much money as they can. I mean, just call me.
Well, I think this is one of the complicating factors for the government is that, they are required to work through these private plans to offer the benefit. And, right, so unless there is a fundamental change, and, we are starting to see price negotiation for the first time ever in Medicare later in the next couple of years
Yeah,
for
but
a
that's just
small number of
insane.
drugs.
Yeah, it's just insane,
Right,
right?
yeah, it's taken
So
forever,
why
but
don't- I
foot
mean,
in the
you-
door.
So Stacey, you know this stuff a lot better than I do. It's just like, why doesn't somebody CMMI say, okay, you create this private entity that operates like this so that we can buy from you? Is that feasible? Or is it, are these?
That's a really interesting idea, yeah.
Yeah, right. So, or is it, these are contracted for 5-10 years already and we can't get out?
One of the challenges I think is often, so if you wanted to try that in Part D, the Part D plan sponsors, the plans would need to sign up and participate. So I think there's a fundamental mismatch between the plans right now, if they don't have the incentive to be getting the lowest cost, they will
Yeah.
continue business as usual.
Right, because the way I understand it, right, once they get to certain limits, then they go into the reserve slush fund or
Yeah.
whatever, and they get paid from that, correct?
Yeah, yeah.
Particularly with Medicare Advantage. And so they have.
Just start calling reinsurance the reserve slush fund. I am taking that.
Yeah,
I
because
love
it is, right? Because once they get to a certain threshold, the taxpayers just write them checks.
Yeah.
And they
Yeah.
have every incentive to get to that threshold. That's the way I understand it.
Yes, absolutely.
So it's just like, we talk about urologists, but we need some proctologists,
Yeah.
Well done, the medical center.
Well, I just want to say, look at the magic that's happening here. I mean, I think we're really at the forefront in these discussions of innovating, pushing the envelope, and figuring out what the solutions really are going to be. So truly, this is amazing to be a part of. Now, we're talking a lot about generics. Let's switch gears a bit and talk about brand name drugs. What is the current status of brand name drugs in Cost Plus, and where are things moving towards?
We just signed a deal with Tirosint or ABSI, I forget the corporate ownership, but Tirosint, which is a branded form of generic Lavoxitine or Synthroid. And so that's our first step. We are talking to a lot of brand manufacturers now. We'll have some announcements in the not too distant future. So we will be adding brands. And so it's just a question of when. And, why do brands want to work with us? Because they get excluded from formularies for ridiculous reasons.
Yeah.
And so now that, we're up past 2.1 million accounts and growing every day, now they see that we have a base of lives that we cover that they want to reach. And that's one reason. And the other reason, why wouldn't they? Because there are so many crazy rules that are written into contracts. It's just like for Vanderbilt to buy from us as a corporate employer, we could save a fortune, millions and millions of dollars, but you've got to get out of the contracts and deal with all the legal side of it. It's just, as a reference, with the Mavs, we self-insure, and I had them look over 18 months, I think it was, generics that we carry that cost $30 and over, and it was like $165,000 that we had paid, and through Cost Plus, it would have been $19,000. And so we're more and more, we're getting a lot of self-insured employers. But to your point, because we're building that base of lives quickly, we're adding brands and we'll be adding more.
So lots of expansion, lots of increases in volume. Have you been able to keep up thus far?
No.
Have there been any? I was going to ask,
Yeah.
I hear stories of delays in some cases.
Yeah.
Tell us about that and what your plan is, how to solve those issues.
So there's been two issues. One, where we're just backed up, right? And so instead of it being 3 to 5 days to deliver, it might be 7 days. And so while it doesn't make us happy, it's a reality. And we try to communicate to let people know. And the second is you run into shortages, where manufacturers, we've just, someone told us that we have more than 5% of the tadalafil market and growing. Now, I think it's just because I've told all my friends.
Yeah.
And
I was going to say that is one of the biggest things that I talk to patients about in clinic, because tadalafil, aka brand name is Cialis, it's not accessible for a lot of patients, especially in the post-prostatectomy.
And we're cheaper
space.
than M&Ms now.
Yeah.
I mean, seriously, you can have a little bowl next to your bed. I mean,
Don't give anyone ideas.
No, we
please.
want those
Okay,
ideas,
not
right?
going to see them in the
The fertility rate in this
room.
country is going down. And so, I mean, literally for like 90 before shipping, we're like $8.90.
Yeah, that's
Better than
amazing.
M&Ms, right?
Yeah.
Who knew
In
chocolate and
today's
peanut butter
economy,
could be so
probably
good? Yeah,
better
right?
than M&Ms.
Right? So yeah, we're starting to deal with growing pains, but part of our response to that, and we haven't formally announced anything, but we've talked about it, is we have an affiliate pharmacy network that we've put together.
Okay.
And what we're doing is working with local independent pharmacists and potentially some grocery chains where if mail order isn't appropriate to you, or the drug isn't appropriate for mail order, or you need it today, you'll be able to go to one of our affiliate pharmacies and pick up your medication right there, as you might have historically.
That's great.
And that'll help a lot of people, and that'll help with our demand because, there'll be a local pharmacist. And plus, we want to support local pharmacists.
Yes.
They take the brunt of all these things we've been talking about with the big 3 PBMs, et cetera. It's wrong and challenging for them where, when they get sent by some of the discount cards or some of the people that the PBMs, when they get sent a prescription, they have to pay for that. It's insane. Like, it's $10 because they think they're going to make it up in selling toilet paper and Advil. And they should be rewarded and paid for their time. And so we're putting together that program that'll allow us to scale even faster.
And that's a real win-win in my view. I mean, you're helping those small local farms.
And they're not necessarily even small, but yeah.
Yeah.
Because they're disappearing.
Yeah.
And it's unfortunate because they give great service. They're not in the political forefront with a lot of the issues. They just want to take care of the communities they serve. They know their patients. We want that personal attention because, it's better for adherence. It's better for so many reasons, and we want to support them.
Yeah, and I think just to follow up on that, having that in person, that person who's kind of overseeing all of your care, one of the things that I think has been brought up over the years as a concern around people getting their drugs at many different places is there isn't somebody who's looking at everything that you have, removing those redundancies,
Yeah.
thinking about the interactions of drugs. And so having the options for some people to be able to still interact with their regular pharmacist
Sure.
and have that oversight is really important, especially for people with multiple complex conditions.
I totally agree. I've heard rumors about a manufacturing facility.
Well, it's not rumors. Yeah, we announced that we were doing it.
Yeah. So what's the update there? Because that should help some of the volume issues, right?
Well, two different things, right? So we're building a robotics factory to do injectables, and generic injectables initially in Dallas. And those of you who run the hospital know that there are a ton of shortages all the time.
Yeah.
Pitocin, sterile water, et cetera. And it creates real problems, you know, in terms of the surgery decision-making. And so we built a facility that hopefully
It all
will be
counts.
open at the end of the summer, where we'll have a capacity of about 2 million vials to start.
Great.
Where, you know, the way so that any of the injectables that are on the FDA shortage list, we'll see that they're work with different hospitals and manufacture them to order, go through the 2-week quality assurance, and then make them available. So, because you're not going to hit all the shortages all the time, and we won't be able to fulfill enough for everybody. But it's a start to try to have an impact. And so that's where we'll start. And if and when that all works well over the next couple of years, hopefully we'll be able to expand that dramatically so that we'll be able to do not just injectables, but other medications as well, generic and otherwise.
That's great. What have been some of the biggest challenges as you've embarked on this journey with Cost Plus?
I think really just scaling and just being patient. It's not really legislative. It's not really competitive. It's really just going through and adding all the medications that we can add. I mean, we have a very, very simple business. We buy drugs, we sell drugs. But our, you know, and our product basically aren't medications, it's trust.
Yeah.
Because in the whole supply chain, if you will, of patient care, you trust your doctor and you trust nothing else. People in the industry don't trust anything else,
Yeah.
right? You don't know what you're going to pay. You don't know what you're going to be charged. You don't know when you're going to be charged. You don't know what happens. You know, there's just so many uncertainties that it creates a lot of fear. And so, you know, through our transparency, we really just wanted to build upon trust. And so our challenges really have just been being patient and the time it takes. And, you know, I'd be lying if I said, oh, we knew we'd have 2 million accounts, you know, 13 months in. We expected to have 200,000 accounts, 300,000, 400,000 accounts. And we would have been, you know, happy as a pig in mud, but here we are. So we've just got to be patient and keep on adding more and more medications. And please, you know, you guys, my email is mcuban@gmail. So if there's a generic that we don't carry right now, just send along. We don't do controlled substances. I don't think we'll do those for quite some time, but other than that.
Well, we have a long list,
Yeah.
Stacey and I can tell you. We got a long list, you know, just to shout out some of the people who have already reached out: vaginal estrogen, mirabegron, you know, all of those. So we'll certainly keep you updated.
Yeah, and I, you know, we talked about the example earlier. I had a friend who was in a car accident and was paralyzed, and through a mutual friend, he got a hold of me and said, you know, Landon, our buddy, he's being told he's going to have to pay $30,000 every 3 months for Droxidopa. I didn't know what Droxidopa was, so I'm like, is it generic? I Google it. Oh, it's generic. I'm like, let me see if we can get it. $30,000 for 3 months?
Crazy.
Okay, you know, we got it, $61 a month.
That's amazing.
And there's just example after example after example after example. Imatinib, right? You're still, if you know, you get prescribed imatinib, your chemotherapy, I mean, all of a sudden you walk into the pharmacy and they're asking for $2,000. Why do they ask for $2,000? Because they can.
Yep.
Because, you know, way back when there was this commercial, I'm dating myself, but there's a thing called Epson printers, 80 character per second dot matrix printers. And they said, Epson charges $99. And then they have this guy, we charge $4 million for our printer, but it's the same as the Epson. Why? How can you charge $4 million? Guy stands up and says, All we have to do is sell one. And that's the way they look at these medications. You know,
Yeah.
if you're, you know, at one of the big three pharmacies and they just got $2,000 or $30,000 for 3 months from you guys, they made their numbers. They're happy. They don't care.
Yeah, yeah, absolutely. And, you know, I will say for the record, in the prostate cancer space, abiraterone's the same story. So I think what you've done there, you know, as a urologist and urologic oncologist specifically, it's changed the lives of a lot of patients. So thank you. What are your thoughts on big players like Amazon and other really well-known companies that do have that public trust entering this space as well?
You know, more power to them. Anything that pushes patient pricing down lower is a good thing, but, you know, you always, again, who takes less?
Yeah.
You know, and so if you're already an Amazon Prime customer and you pay $5 a month and you only order 30 pills, you know, a 30-day supply, you may be able to get it cheaper from Amazon. But if you order a 60 or 90 or 120-day, or you can order longer, you're going to get it cheaper from us.
Yeah.
And so, you know, there's a lot of gamesmanship that's played, but we don't care. The more the merrier. Anything that ends up benefiting everybody. You know, again, our number one product is trust. And our feeling is that if we take care of the patients and we work really closely with the pharmacies we partner with and take care of patients, people are not going to want to change because they trust us.
Yeah, absolutely. And that's why your face is on the company.
Well, it's the only company I've ever put my name on. And, you know, even though my daughter like rolls her eyes every time, but, you know, it's just like, you know, I wanted people to trust us. I wanted people, because when we first got it started, you know, we were just one more company that was going to try to change healthcare and drug pricing. And there's been a long list of companies that have come and gone to try to do the same thing. And, you know, that's one of the benefits of Shark Tank. At least people know my name. They may not like me, but they know my name, and, you know, they know I can afford it. And so I wanted people to know this is the only company I ever put my name on and the only one I ever will.
Yeah.
I think that's one of the great benefits too of how transparent you are with pricing and the information you put out there for people, because having worked in this space for a really long time, there have been others who have come and tried to go into this area, or who have decided they want to go with a really great mission of saving people money, but then as it gets closer to the point where they could do it, they change direction and they act
It's
like
expensive.
everyone else in the industry.
You know, I'm not gonna lie. If I was 25 years old and started this and somebody offered me $1 billion, I'm like, see ya. Hello, Dallas Mavericks, you know, but you know, where I am in my life now, I just want to do it because, you know, I don't want to put my names on buildings. I want to do something my kids are proud of.
I love that. That's great. So policy changes. We've talked about a couple things that we, as three people, you know, just spitballing here, think could make an impact in this space. But Stacey, tell me about what you think needs to happen next to kind of improve access to prescription drugs and ways that Cost Plus can fill that void.
Oh gosh, it's hard to go down this route without trying to simplify the system dramatically. I think one of the problems with our current system is there are too many entities in it who are making a lot of money. So I'm really super popular at cocktail parties when I say things like this, but I think everyone—
That makes you popular?
Everyone, no, it's what's coming, Mark.
You go to big parties.
It's what's coming. Everyone in the system will have to make less money if we want to fix this for patients, because we have really reached a point in the society where health insurance costs alone, just to have health insurance coverage, is crazy expensive. You know, it's average of over $20,000 per year for a family premium, just to have health insurance. And that's usually not coverage that is helpful to you if you need to get care.
Yeah.
And so I think that we really have to look hard at our system and think about how to streamline it and simplify it in ways to really make it work better for patients and less costly overall. But it will mean that everybody needs to take less, because there are many, many people taking from this particular pie.
Yeah, well, it's time to shake up the space like you've already done, because it's not sustainable. It's not sustainable for individual patients, for families, for health systems, or taxpayers in general. So I think, you know, I think that a lot of this discussion we're having is going to drive basically what we see moving forward.
It won't, though. It really, really won't.
I'm an optimist, I guess.
Yeah, it won't. I mean, you know, maybe there's an opportunity for us to work together with Vandy in terms of, you talked about the types of organizations that can bid to CMS, right? Maybe we can prototype one of those and go to CMS and say, okay, here's how you buy and pay less. Maybe, you know, I know at the Mavs, we pay for a family of 5 we self-insure, my cost is more than $30,000 a year.
Yeah.
I'd rather give that right to the hospital
Yeah.
than to an insurer, because, I mean, just look at the ACA, the MLR is 15%, right, 85%. So for a payer, and even some of the hospitals, it's like, how do I make more money? Well, the bigger the top line, the more that 15% represents. So people push to get a higher number. I mean, that's how we get rewarded. That's got to change.
I think what I heard him just say is Mark Cuban Part D plans.
Yeah. I mean, I don't know how to do that, though. That's
We'll
the whole thing.
figure it out.
I really don't know how to do it. I'd love to be part of a plan where, you know, the Mavs or organizations here can just pay directly to a hospital and say, you're covered, right? You know, simple contract. In terms of legislation, why is there a different contract that you guys have to fill out with the insurer every year?
Yeah.
Because that's just it. So if you want to pass one law that I would request, that you have to use this, in the NBA, there's one universal player contract, the UPC, right? And we see that in a lot of different industries. There's just one master contract. Every contract should be one master contract between payer and provider. That's it. And you can change the numbers, but all of a sudden, it all simplifies.
Yeah.
And once you simplify the administration cost, at least you start to, you know, create 5% or 10% margin, which is huge in this industry.
And I think that's where your plan for even adding brand name drugs and things like that, it's like your plan, it simplifies the contract. It says you're not going to have all these hidden rebates,
Right.
other negotiations. Tell me what your price is, and if it's low enough for my customers, it's going on.
Bingo, that's it, right? Just simplification. And look, the drug manufacturers love this approach because they've been demonized.
Yep.
When you walk down the street and said, who's responsible for insane drug pricing? Oh, the manufacturer, right? These pharma companies are just out to get us without knowing. They don't even set the price for their own products.
Yep.
Unless you have a one-off drug that's just huge that everybody needs, you know, the PBM is doing more to set the prices we've seen with insulin.
Well, you heard it here, folks, okay? We have the Mark Cuban Part D plan and maybe the Mark Cuban other collaborations.
Hospitals,
that are in the
yeah,
works.
okay,
Yeah, hospital insurers, all that.
But I'm serious about doing that.
Well, you gave everyone your email address, so how are you going to even
Exactly.
find my email?
Trust me, I get 1,000 emails a day. I read that first line,
the
delete,
filter.
delete, delete, delete.
So what are the magic words? How do we make sure you
Mark
read our
Cuban
email?
Part D
Oh, it's really
plan.
easy. No, have a check for you.
Well, as our time comes to a close, I just want to again thank you both for joining me today in this really important discussion. Thanks to all of you who are here with us in person, as well as those who are joining virtually. I think there's a lot of work to be done in this space, but again, I'll say that I remain optimistic with some of these minds up here pushing the envelope, disrupting the industry. I think you're going to see a lot of good come out of, you know, the reform for prescription access in America. Thanks again for joining.